and WHO website. So it's important that when we get this the topics that we cover, we go and look up information about these topics on the CDC and WHO websites. CDC and WHO usually have more up-to-date information about those respective topics, and it helps us to keep up to speed with the changing times for the respective conditions we shall have discussed. The other important thing to do is to definitely make time and look at the articles that I'll be sharing. I know we most of us, me inclusive, have had a challenge over time to get down to read some of these articles. You feel it's a lot of work and the likes, but then it is the only way you can shape or forge an opinion or an understanding of the particular condition we are talking about in relation to your country of residence. Most of the information I'm sharing is one that can be appreciated by anyone, whether you are Ugandan or not. So you will find that, Derek, some of the articles I've shared with you are WHO and others are purely Ugandan. The most recent of the studies that you'll see is a 2020 study on assessing providers' approach to hypertension management at large private hospitals in Kampala, Uganda. So ideally today we're supposed to start our session by looking at ICD, or International Classification of Disease. However, I shared a link that has an exhaustive enough PowerPoint. I will share also a link of a video. Mainly what you need to appreciate about International Classification of Disease is that it is a systematic approach to classification of disease, paying special attention to mortality, morbidity, mortality, burden of disease, pathophysiology, which accounts for the clinical components, and then pertinent to note, diagnosis and treatment. The ICD was mainly introduced to ease clinical management. Sorry? The ICD was mainly introduced to help us understand how to approach disease. So as you do your read up, you'll discover that diseases are categorized in different big classifications. So you'll have things like infectious disease, you'll have oncology or cancers, you'll find you have endocrine disease. Infectious is the communicable. So you'll have communicable and the non-communicable. And then you'll have injuries and the likes. And in there, you'll find other sub-classifications which give more like a somewhat subtle case definition that will help us make a decision on what each of these are. I believe this would not be the first time we are coming in contact with International Classification of Disease, since it's commonly taught, especially in psychiatry and mental health. So we also have a section of the ICD that looks at mental health or psychiatric illness. Class, are we together?
Yes, we are, Mr. Samuel.
Yes, we are together.
Yes, sir.
Okay, so currently we are using please, when you join, mute so that you do not interrupt our session. Derek, after at 9:30, please take a screenshot of attendance and send it as usual. So the other thing you need to appreciate about ICD, or International Classification of Diseases, currently we are using the ICD-10 manual, and I think around February or January next year, we should be rolling out. I have seen copies of the ICD-11. I think I'll share a link with Derek. You can also have a look at it. I'll also send a PDF of ICD-10, but then ICD-11 has obviously modifications, like how you have a BNF. We have a BNF coming out every year. Why do we have a BNF coming out every year? There are new drugs that are rolled out on the market. There are some drugs that are removed from the market. There are some drugs that whose indications change. There are some drugs whose doses for maybe prophylaxis or management become altered over the time. And this is the reason as to why this information should be updated, meaning there is a group of people out there that is constantly carrying out research to furnish us with the up-to-date information pertaining some of these concepts. So the ICD-1, some of the medications, for example, I've seen in ICD-11 is approach on, I'll take an example of mental health, because psychiatric illness is one of those things that ideally we should be talking about in non-communicable diseases. But because of how short the duration is, the credit units, we're just going to cover something superficial. And in the introduction sessions, I'll share with you how the ICD-11 is currently approaching homosexuality, because earlier on homosexuality had been termed as a psychiatric disease, but then in the recent classifications, it has been extracted from this psychiatric illnesses because there is evidence to the contrary. So it's usually very important to keep up to date with some of these conventionally recognized documents that you'll be utilizing in your day-to-day practice. I know some of you are saying, but why would I need the ICD-10, ICD-11? I'm just going to practice. Who knows? I also didn't know I would end up here conducting lectures. So you need to be up to date, even if you're just going to be practicing in your peripheral unit out there. So some of this information will be important to you. So Derek, when you share this content, let guys read through. I will send you the official PDFs because I sent links. You can read through, and then just in case there is anything that we can share out of that, you can let me know. So according to our outline, today we shall be looking at hypertension. And earlier on, before you joined, I told Derek that we are going to be discussing, and you people are going to be taking down notes as we share, because most of this content we have interfaced with. It also helps us to pay attention. It helps us to participate, and also aids us to synthesize this content as we move along. So the most recent publication shows that the prevalence of hypertension is around 20 to 25%. That is a 2020 publication. But the closest to that is a 2015. There are two 2015 publications, one by a senior cardiologist, Dr. Kaima, and another by, I think he must be a physician, Dr. Gwatude. All of these show a slightly lower prevalence of hypertension, which is around 7 to 15%. So if we are to look at the 7 to 15% with the 20 to 25% in 2020 vis-a-vis the other in 2015, that shows that the burden of hypertension is growing in Uganda over time. The most interesting bit is that Dr. Kaima conducts the study in young adults, and he looks at the course taken over time to change from normotensive to abnormal values. So these are articles that I would be so happy if you guys took off time to read, because I've shared the articles with Derek. So that would mean that we would have to use our basic epidemiology and biostatistics to interpret this information and say that if we're looking at 100 people, 100 participants that were enrolled for a study that these guys in 2020 were carrying out, we are saying that 25%, 25, I'm using the upper value. We are saying that 25% of these individuals are hypertensive. So that would mean if we are to take the total percentage of respondents as 100, we are having 25 per 100 of the participants hypertensive. This is a big value, considering that the leading cause of morbidity and mortality in non-communicable disease are cardiovascular disorders. The cardiovascular disorders are very many. If you'd agree with me, they'll range from the non-specific heart failure down to hypertension, down to coronary artery disease, down to degenerative myocardial disease, rheumatic heart disease, infective endocarditis, pericarditis, and the likes. But then we want to stick to the non-communicable bit. If we talk about non-communicable, we had a definition the day we made our inception lecture. And we said the degree of the concept of infectiousness lacks within the non-communicable disease. However, we said we cannot completely deter the aspect of infectiousness from non-communicable disease, since some infectious or communicable diseases can complicate into non-communicable diseases. So we said it is a plus or minus. We can have non-communicable diseases that completely have their genesis isolated from the infectious agent. However, we said we have those for which their genesis has a component of infectiousness at the center. I hope that is clear enough. So this is what we are saying. We are saying that when you look through all those diseases, you look at hypertension, you look at infective endocarditis, previously called subacute bacterial endocarditis, you look at coronary artery disease, you look at rheumatic heart disease, you look at pericarditis, you'll be able to apply your concept of non-communicable disease, and you shall come up with a consensus that, for example, degenerative myocardial disease, commonly called cardiomyopathy, is non-communicable. Hypertension is non-communicable. Coronary artery disease is non-communicable. I hope you guys are taking down notes. We've agreed. We are going to discuss as we take down notes. So it means that in that lot, infective endocarditis has infectious agents at the center, so it becomes communicable. But remember that infectious endocarditis, as much as it is communicable, it can complicate into long-standing or chronic valvular heart disease, which later on, even with clearance of the infectious agent, can persist and cause debilitation in this particular individual. So this is what we are talking about. We are saying it is very difficult to completely isolate infectious disease from this non-communicable concept we are talking about. So each time we say that amongst the non-communicable diseases, cardiovascular disease carries the largest burden, in there we have a number of diseases. And in the non-communicable cardiovascular disorders, hypertension, which we are talking about today, carries the biggest burden. Throw the question to the hypertension in Uganda. how it has been, how it was, how it is, meaning we are appreciating the trend that this particular disorder is taking. Remember, hypertension is a modifiable risk factor for very many other complications like we shall see. So the idea behind studying hypertension as a non-communicable disease is to understand the pathophysiology, the risk factors, how we can diagnose it, and then what is pertinent to us as public health practitioners, how can we prevent it? Keeping in mind that hypertension is a risk factor for a number of diseases, that would mean that by preventing hypertension, we are preventing, for example, stroke. We are preventing heart failure. We are preventing renal failure. We are preventing blindness. If you look at causes of blindness, you will see hypertension somewhere. That would mean that if you address issues to do with hypertension, you are likely to stop some of these complications from occurring. These complications can occur as diseases on their own. So that's why, or that's how hypertension now becomes a risk factor. Yet we are talking about it right now as a disorder which has its own risk factors. Class, are you understanding the direction I'm taking?
Yes, we are.
So I would like to pose a question. I would like to pose a few questions. I'll ask Sharon Nanduja. Yes, Sharon, what is hypertension? So we can, Derek, please mark.
Yes, please.
Mark Sharon absent. Let's move on. Stewart, what is hypertension?
I'm here, sir. I'm present.
Give us an answer very fast. We don't want to waste time. Stewart, first wait. Sharon? Sharon, what is hypertension?
Hypertension is defined as when the blood pressure is above 140, like that is systolic, and then the diastolic at 90. That's what I know, sir. So,
Sharon,
yes,
thank
sir.
you very much. Thank you very much. I want us to exchange a few ideas. So, Sharon, I've worked in. Sharon, are you a clinician by background?
I'm a midwife, sir.
No, a midwife is a clinician also. Don't worry. So,
Okay.
Sharon, if I walked into a clinical room and you are the attending clinician and you measure my blood pressure and it is 145 over 100 millimeters of mercury, or over 90 millimeters of mercury, you're saying we make a diagnosis of hypertension?
Yes, sir.
Okay, thank you. Stewart, do you want to modify Sharon's answer? Because Sharon is telling us the truth, but we want to get the crystal in the truth is what is missing. So Stewart, when does a blood pressure reading qualify as a criteria for diagnosis of hypertension? Derek, Mark, Stewart absent. Derek.
Yes, sir.
Yeah, Mark, Stewart absent. If you guys who are on call today, if I call you out and you are busy on Google looking for answers, we shall mark you absent.
But sometimes it depends on someone's network.
Cotias, when I want you to speak, I will ask you to unmute. Kindly. Stewart, just a second. I want to have some order. Stewart, we are hearing you. Just a second.
Hypertension. Oh, sorry. Okay.
When I want you to speak, I will tell you to unmute. Do not unmute to speak when you haven't been given permission. Please, let us have some form of order. I don't know if this is how you've been used to doing your things in the past, but that should stop with today. I want everyone, if you want to answer, for example, Cotias, if you want to answer next time, You go to the chat and see what Evelyn has done at Kunzire. Her hand is up. Don't unmute. Don't even attempt. So let me repeat. When we call out your name, if it is network that is an issue, quickly type in the chat. But the things of going on a call and you can't do other things, no, we are going to have a problem then, and a very big one. So let's go back to Stuart. Stuart, did you hear Sharon's answer? I want to repeat, Sharon's answer was correct, but we want to modify Sharon's answer.
Yes, I had it. Sorry, I'm downloading those slides, so my network is still slow. Those slides you shared. Hypertension, I would define it as persistently high blood pressure taken at this 10 minutes apart on more than one occasion. I think my assumption is modification. I don't know about the exact, but it should be persistent. When the patient is in a resting phase, then I think 1 week apart or something like that, but there's a duration. It's not like one reading will give you definite blood pressure, like a definition. I mean, a diagnosis of blood pressure. Yes.
Okay, thank you very much. I will take, my friend has disappeared. Evelyn, was the answer similar to that Stuart has given us? Evelyn? Have I lost Evelyn? Yes, Evelyn. Evelyn, you're speaking. We are not hearing anything. Okay.
Yes, I wanted to.
Yes, I'm hearing you.
I think it's.
Now I think it's network. Evelyn, can you quickly type in the chat as we receive?
I wanted to add that.
Yes. No, I'm hearing you now. Carry on. Oh, sorry, we have lost her. Can I quickly take Derek? Then I come to Justin. Derek?
Thank you very much, sir. My addition is just we also have to take a look at the age as well, because you look at those probably look at below the standard is around 65, and then those ones that are above 65. So you might get a reading when someone is probably above the years, and you look at it can be considered to be normal. But you look at the other one below the years, it can be abnormal. So age should be also to be put into consideration. Thank you.
Okay, thank you very much. So Derek is giving us one of the risk factors to hypertension. One of the risk factors, we are going to say age. So age, the older you get, the higher the chance of developing hypertension. Cotias is asking, does age have an effect on hypertension? Cotias, very well and very true. It does. The older you get, remember Cotias, the higher the chances of you developing hypertension. Why? Physiological and anatomical changes. As you keep on aging, the ability of the body to replace elastin within the blood vessel wall becomes impaired. And remember, we shall go back to the blood vessel wall and ask ourselves, what are the contents of these three layers? When we said that the blood vessel has tunica intima, tunica media, tunica adventitia, or the inner, the middle, the outer. What are the contents of these layers? How important are the contents of these layers in permitting normal physiology to be performed or achieved by a blood vessel? So the older you get, Cotias, and like Derek has told us, the more difficult it is for your body to replace elastin. And as a result, there is a tendency of the blood vessel to harden. We refer to this as arteriosclerosis, not athero. Remember, athero will happen at any age, as long as you're having deranged lipid metabolism. You'll have atherosclerosis. This is arterial, I'm saying. Class, are we together?
Yes, we are.
All right. So now, Kamia, is this Justin? Is this a new hand or you have a submission?
Yeah. Okay.
Yes,
okay. What I wanted to talk, Derek has talked about it, because we normally say hypertension is abnormally high blood pressure, whereby it depends on the age. But now these days in the clinic, some clinics, they can say 130/90 is considered as normal, but still according to the age.
Thank you very much.
So also my factor was about the age.
Thank you very much. So we all now unanimously agree that if you're going to make an interpretation of high blood pressure or hypertension, you'll need to add a component of age so that you do not misclassify individuals. Now, let's quickly leave that. We have now defined hypertension. But if you look through the chart, ladies and gentlemen, there is some interesting information that I wanted Derek brought it to our attention, that I wanted, what's her name? The first participant, I forget, that I wanted, why am I forgetting that I wanted Stuart and the lady who gave us a definition, Sharon, that I wanted Stuart and Sharon and the rest of the class to appreciate. For us to decide that this patient has high blood pressure or hypertension, we need to understand cutoff values. The only way you're going to understand the cutoff values, ladies and gentlemen, is by understanding the normal. Now, I am taking us through these things that seem like basics because I will assess them. There's no way you can be tasked to go out to organize and conduct an NCD clinic targeting hypertension screening, health education, appropriate referral, and you get there and you don't know normal blood pressure reading. I have seen these on a daily. You ask a principal clinic officer, you ask a nurse in an interview, what is the normal blood pressure? They start stammering. It is unacceptable. So what we are doing right now is we are attempting to look at the normal, and the normal will help us judge what is abnormal. Already we are having a criteria for judging abnormal as age, that each time you want to interpret, look at the age of the individual, because in some, the value that you're looking at will be apparent normal. Also, look at some of the conditions that the patient, pre-existing conditions the patient is having, apart from the hypertension, like we shall see later on. The target blood pressure, target control of blood pressure in a patient with pre-existing renal disease is different from that one of a patient who has no pre-existing renal disease. A diagnosis of hypertension, the cutoff value in a patient with pre-existing renal disease is different from that one who has no renal disease. So you'll notice that there are some compelling indications that can change our criteria, meaning that our definitions are not cast in stone like the laws of Moses. Today is Sunday. They are not cast in stone like the laws of Moses. You can shift them to accommodate certain patients. So don't ask Derek, Stuart, Sharon, and the class. Don't ask yourself why this patient with pre-existing renal disease is receiving an antihypertensive at a BP of 130/80 millimeters of mercury. Not it, but some I think would wink at us. This guy's BP is normal, but the doctor is prescribing for him antihypertensives. How possible is it? Remember, when you have a compelling indication like we shall see, we are saying that you have hypertension, but you're having another condition that can easily worsen the hypertension and cause deterioration of the patient, or hypertension can worsen that condition and cause deterioration. So you'll notice that, for example, one of the ways of reducing the incidence of hypertension in diabetic patients is by introducing antihypertensives. In particular, we shall look at the antihypertensives before the end of this session. We shall talk about the drugs. We're going to look at antihypertensives, which exert their effect by manipulating one of the arms of control of arterial blood pressure, that is the renin-angiotensin system. or what some people refer to as the renin-angiotensin aldosterone system. Please pay attention, because I am very certain the class has midwives, clinicians, laboratory technicians, it has some direct students, etc. You need these concepts. It's like how you enter in medical school first semester, first year. You can't say, no, for me, the combination I did was the BCG. I don't know if BCG exists. Biology, chemistry, geography, and something. That's it. For my studied BCG. No, don't start with gross anatomy. You start with the definitions. No, it's unacceptable. It is a curriculum. Why I usually go through the course content first is that you understand the direction we are taking. So let's go back to this. Any blood pressure, ladies and gentlemen, that is below 120 over 80 millimeters of mercury is normal. Does that make sense? Are we together, class?
Yes, sir.
Any blood pressure less than 120 over 80 millimeters of mercury is normal. But remember, ladies and gentlemen, this is upper limit. This is upper limit. The first patient I managed as a clinician who had, we are going to talk about the hypertensive crisis, and we shall subclassify the hypertensive crisis into emergency and urgency. The first patient I managed in a hypertensive crisis had a blood pressure of 200 over 180 millimeters of mercury. And I remember administering, Stuart is asking, what about hypotension? Stuart, thank you very much. But I am assuming, Stuart, you're not a Muganda, because in Uganda, when you are eating ruombo, you don't poke the ruombo. I don't know. Derek, are you Muganda?
Yes, I am.
But we have, Derek, you know this saying of Sumuluro Suna. So, but Stuart, the question you have asked is what I'm trying to address right now. That as much as we say that all blood pressure less than 120 over 80 millimeters of mercury is normal, that is upper limit, meaning we should have a lower limit, so that we say that any blood pressure less than 90 over 60 millimeters of mercury is abnormal. Because remember, we have two deviations from the norm. The norm is normotensive. So we have a lower deviation, which is hypotensive. And then upper deviation. Hello, are we there?
Yes, we are, but you've been breaking.
So I hope you understand. I hope you understand what Stuart's concern is. If we are saying all less than 120 over 80 millimeters of mercury is normal, what is the cutoff for hypotension? And we have discussed that. So my first patient had 200 over 180 millimeters of mercury, and what I had at my disposal was oral medication. So I gave 80 milligrams of furosemide and gave the patient a start dose of sublingual nifedipine. I don't know if you people have used sublingual nifedipine. However, I did not titrate my dose adequately. So my patient came from 200 over 180 millimeters of mercury to unrecordable BP. Unrecordable. I was very lucky the patient didn't die, because we then initiated a resuscitation protocol, which very many clinicians in practice have not yet learned. So as much as we are saying anything less than 120 over 80 is normal, we should have a target, and we are going to see that as you initiate your patient who is even pre-hypertensive on, for example, lifestyle changes, you must give them a target BP control, or a target BP control, something they will look at. Even you as a clinician who is managing, You should have a target. If a patient came in with 180 over 120 millimeters of mercury, what is your target? To bring the BP to 100 over 80? So we shall say any reduction in 5 to 10 millimeters of mercury, unless otherwise is sufficient enough. Because each time the pressure increases, some compensatory changes occur, and those compensatory changes, once abruptly removed, can cause what? Death to the patient. So let us quickly proceed. And we have now talked about what hypertension is. And we are saying that you should take the readings at least on 2 separate occasions, on separate days. It could be 2 days apart, 1 day apart, etc. But it should be 2 separate. If you're familiar with in epidemiology, we talk about sensitivity and specificity. And inside there, we talk about validity and reliability. One of the things that is very important when you're measuring blood pressure, ladies and gentlemen, is reproducibility of the results. So the blood pressure should be measured on both arms. It should be taken when the patient is at rest, and it should be on 2 separate occasions. A blood pressure greater than or equal to 140 over 90 millimeters of mercury is abnormal. However, there is some bit of contradiction here. We have normal as less than 120 over 80 millimeters of mercury, but we are saying abnormal necessitating initiation of therapy is 140 over greater or equal to 140 over 90 millimeters of mercury. Who are these guys inside in the middle? We usually refer to any blood pressure from 120 to 139 over 80 to 89 millimeters of mercury as prehypertensive. Now, if you look at the American College of Cardiology, the publications, you look at the Joint National Committee on Prevention, on Diagnosis, Prevention, and Treatment of Hypertension, all of these currently recommend that, okay, let's start with what it was previously. They would previously recommend that a prehypertensive patient should be initiated on vigorous lifestyle changes and the risk modifications, so as to stop them or protect them from developing hypertension. Currently, these recommendations have changed. They recommend that in addition to lifestyle modifications and the modifications of manipulation of risk factors, a patient should be introduced on at least 1 drug for treatment of hypertension, because studies have shown that most of these people, because they do not actually fall in the category of saying they have a disease, they do not adhere to the recommendations. And as a result, they'll develop hypertension. In Uganda currently, you have seen patients who are taking Lasix alone, patients who are taking amlodipine alone, and they're taking small doses. Initially, most health facilities would initiate patients on Aprinox. I don't know if you're familiar with the drug Aprinox. So they would introduce the patients on Aprinox. Aprinox is a trade name for benzoflumethiazide, which is a thiazide diuretic. This would improve on salt and water homeostasis in the body, and as a result, would reduce the patient's blood pressure. So I hope you understand what we are talking about. So we are having now 3 categories: a normotensive, a prehypertensive, and a hypertensive patient. But even inside there for the hypertensive patient, like we are going to see, you can be hypertension grade 1, hypertension grade 2, and then you can be the hypertensive crisis, where we have hypertensive urgency and hypertensive emergency. Now, before I take that direction, I want to quickly help us. There's a question here. Ruth, can you unmute? Ruth, are you there?
Yes, please.
Yes.
So my voice is hoarse. I have a respiratory tract infection.
No, it's totally okay. We can be able to hear you. So you're saying, according to the American College of Cardiology, 130/80 is?
Normal blood pressure.
Yes, but remember, we are saying this is pre-hypertension.
Mm.
So do you agree that pre-hypertension would be classified as someone who is normal?
Yes, because it does not require medication, but rather someone needs to improve maybe in their lifestyle so that they
Lifestyle
don't
modification. Excellent. So so you're more like consolidating what we're already saying. But remember, we are later on going to dispute that fact and say that current recommendations say that look at if the patient has any compelling indications. If they have compelling indications, put the blood pressure alone, put an assessment of the blood pressure in isolation aside, because that patient will actually progress. The commonest compelling indication I can give you people is renal disease. If a patient, for example, had a blood pressure of 130/80 millimeters of mercury and he had chronic kidney disease, he has a blood pressure of 130/80 millimeters of mercury and he has diabetes mellitus. So you'd try as much as possible to stop this blood pressure from progressing to disease, because the patient has a permanent condition that is associated with the complications of or complication into hypertension. Ali is asking, how do we titrate the doses of hypertensive drugs during a hypertensive crisis? We shall get to that, but I'm not going to go into the deep medical bit. Remember, we are covering introduction, so we need to have just an idea, and then we go down into the prevention. So we shall quickly look through the normal. So in the normal, these are the things that you need to appreciate when you're reading. These are the things you need to look out for. One, what is blood pressure itself? Because we are looking at hypertension, but what is blood pressure? So we are looking at the force exerted on the blood vessel wall by the direct pumping action of the heart. So that means that by all means, blood pressure is generated by the heart as it attempts to send blood into the system. So it means that most of the hypertension or high blood pressure that we evaluate in the patient is what we refer to as the systemic hypertension or systemic high blood pressure. I hope you guys are understanding. Now that would mean we can have other types of hypertension apart from the systemic hypertension. For example, we can have what we call a pulmonary hypertension. We can have a portal hypertension and the likes. But for the purpose of what we are identifying today and what we are discussing today, we shall mainly concentrate on systemic hypertension. So what are the factors responsible for the control, or what are the mechanisms? Let's use the word mechanisms. What are the mechanisms responsible for control of arterial blood pressure? So before you understand the mechanisms responsible for normal regulation of arterial blood pressure, it's important for us to understand that blood pressure is equal to cardiac output times peripheral vascular resistance. You can further break down that formula and make cardiac output the subject of the matter. But what is cardiac output per se? Cardiac output is heart rate times stroke volume. These are basics you should have covered in anatomy and physiology, but we are pulling them out right now because we are going to get to a level of intervention. And we shall say reduce on the salt you are taking. How does that reduce the patient's blood pressure? Exercise. Stop smoking. So all these are targeting certain aspects of the normal that have been altered by whichever risk factor the patient is being exposed to. So when we are looking at arterial blood pressure regulation, it is regulated in two main mechanisms, but different write-ups will give you different approaches. But the conventional is short-term and long term. So short term is usually the autonomic nervous system. And we all know from our anatomy and physiology, the autonomic nervous system is made up of the sympathetic and the parasympathetic arm. So each time your blood pressure is lowering, the sympathetic nervous system is activated. Let me ask, I saw Chirumira around. Chirumira.
Sir, yes, sir.
Chirumira, which part of the, which specific part of the autonomic nervous system responds? Okay, let me make it more simpler. Which specific part feeds input into the autonomic nervous system so as to regulate blood pressure? When we're talking about autonomic.
Yes.
Which part that
feeds
into the autonomic nervous system?
Yes.
To blood pressure. We have at receptors.
So you're saying heart receptors, those ones we shall first put on the side. We shall first put on the side because remember, blood pressure, the response is what goes through the heart. The detection doesn't go through the heart. The detection goes through what, Chirumira?
Detection goes through vagus nerve. I'm sorry.
Chirumira, let me give you an approach. We have the heart, we have blood vessels, we have blood. We want to regulate blood pressure. The sensory input will come from what? Chirumira, network 0.
The blood because of the pressure.
Chirumira, now you type in the Chirumira, type in the chat.
You can't hear me.
Yeah, your network is breaking completely. So as Chirumira is typing, who can volunteer? Who wants to give us a response? What is the sensory input that feeds into the autonomic nervous system for us to control blood pressure? Where does the sensory input come from? Ruth, can you unmute and tell us? Nambi, Ruth, can you unmute and tell us? Ruth has also disappeared. Stuart?
The question is not very clear.
Sensory, Stuart, we want to regulate blood pressure in the short-term control. We have said blood pressure is regulated short-term, long-term. And we've said the principal mechanism for regulating blood pressure in the short term is the autonomic nervous system. Where does the sensory input for the autonomic nervous system to detect and respond, where does the sensory input come from? Yes, Bosco.
Morning, members. I think the heart is innervated by the vagus and then the sympathetic nervous system, and then parasympathetic and then the sympathetic, or the vagus and then the sympathetic. So I think the vagus.
Bosco, what you're talking about is now how the autonomic is going to respond. Where did the autonomic get the message from? Okay, let me make work easier for you. What are the receptors? What is the name given to the receptors that detect and feed into the autonomic for the autonomic to respond the way you have mentioned? Yes, so Ali has given us the correct, actually from Ruth up there, if you look in the chart, the answer is the baroreceptors, Stewart and Chirumira. The baroreceptors detect, and the baroreceptors are found in the blood vessels. Baroreceptors, by the way, are an example of the mechanoreceptors. If you forget the word mechanoreceptors, they're an example of stretch receptors. How? As blood enters the blood vessel stretches. The degree of stretch is measured by the receptor. How? When the blood vessel stretches, the stretch is converted into an action potential within the receptor. So if the degree of stretch is sufficient enough, to beat the threshold receptor potential of the mechanoreceptor or the stretch receptor or a baroreceptor, then the baroreceptor will discharge an action potential. And this action potential will be fed into this. This is the basic, you guys. This is basic stuff. I don't know even why I passed there, because now we are going to have a bit of problem. So this sensory input from the baroreceptors is fed into a control center, like how you must have talked about homeostasis from certificate, diploma, degree. It doesn't change. You have a receptor, you have a sensory pathway, you have an integration center or a control center. You have if sensory is also called afferent. You have efferent or motor, and then you have the target organ where the response is going to be elicited. So we are saying that one of the major mechanisms by which arterial blood pressure is controlled in the short term is by baroreceptor reflexes. Baroreceptors take advantage of stretch, and they feed their information into the central nervous system, where the autonomic is going to respond. Ladies and gentlemen, the heart participates not in detection, but the heart participates in response. So how is the autonomic going to respond? Bosco has given us a clue. Autonomic is going to respond through sympathetic and parasympathetic. The parasympathetic arm to the heart is what Bosco is calling the vagus. The sympathetic arm is also there. Sympathetic arm is aimed at increasing the heart rate. The parasympathetic is aimed at decreasing the heart rate. But remember, also the blood vessels have a smooth muscle. So auto-regulation of what we call the vasomotor tone can alter blood pressure and give you either an increase or a decrease. So I'll ask a question to Bosco. Bosco, normally, what does our body use in terms of autonomic control? Our body is under the influence of more of what? Is it sympathetic or parasympathetic? Which of the two arms of the autonomic nervous system controls the body in the normal state? Derek?
Yes, please.
Of the two arms, sympathetic and parasympathetic, what influences the normal body processes? Or which one predominates over the other?
Parasympathetic.
Excellent. So where we are right now, unless otherwise, the body is under the influence of the parasympathetic arm of the nervous system. However, due to the varying demands with the different executions of the body, the sympathetic is called in. That is not what we are discussing today. So let's proceed. Apart from the short-term control, we are saying we also have a long-term control. The long-term control is short-term and long-term, ladies and gentlemen. Yes, please.
Would that explain why we usually give the Benadryl, the furosemide in response to that the short-term relief of someone with high blood pressure?
Now you see, Derek, the short-term control, if it is autonomic, you have to look at drugs that work on the nervous system. So you will notice and the rest of the class, you'll agree with me that if you want to understand or appreciate the role of the autonomic nervous system, look at a patient being managed in a hypertensive crisis. So when a patient is being managed in a hypertensive crisis, currently, if you have looked at some of the drugs on the market, one of the commonest drugs that has been used time in memory is hydralazine. If you look at hydralazine, hydralazine is a direct acting vasodilator. So do you see what it is doing? It is going to the other bit of the what? Of the control that the autonomic utilizes, and it is removing it so that it can correct the problem. A drug that has lesser side effects that is over the time overriding hydralazine is labetalol. Labetalol uniquely influences both alpha and beta receptors. So it has a balanced effect. So it will work on the heart, it will work on the blood vessels, and as a result, it will give a global reduction. So if you look at those, Derek, I would say, yes, the drugs, but then the example of the drug you're using is wrong. The examples of the drugs you're using are targeting the long-term control. So if we are targeting the short-term control, Derek, drugs like nifedipine, drugs like mainly beta blockers, alpha blockers, drugs that can block the ganglion or ganglion blockers, etc. Those are the ones targeting the short-term control. But where are we originating from? The person who taught you physiology should have told you, if someone got involved in a road traffic accident and got a compound fracture, and as the bone is breaking, it cuts through a major blood vessel and the guy loses a lot of blood, what will protect this guy from dying? What will try to conserve this guy's blood pressure? It is going to be the sympathetic, because the baroreceptors are going to detect the drastic changes in blood pressure, and they will tell the autonomic nervous system, and the autonomic nervous system will respond with the mechanisms that are aimed at preserving the blood pressure. That's why we say autonomic is mainly short-term control. So let me continue. Long-term control, we have agreed. Mainly the long-term control involves things like the kidney. And the kidney utilizes what we call a renin, angiotensin, aldosterone system. As blood class, as the blood enters through the renal artery, the renal artery at the afferent arterial has a baroreceptor in it. So the kidney can also do autoregulation of pressure. So the baroreceptors are situated in a way that when they detect changes in blood pressure, the juxtaglomerular apparatus can be stimulated. So if the blood pressure is low as detected by the baroreceptors in the kidney, the juxtaglomerular apparatus is stimulated. What does the juxtaglomerular apparatus do? The juxtaglomerular apparatus is going to produce renin. Class renin is going to stimulate the liver to produce a plasma protein called angiotensinogen. Renin is an enzyme, not a hormone. So after stimulating the liver to produce angiotensinogen, it is going to go ahead and convert it to angiotensin 1. Now, angiotensin 1 will go through blood going through the lungs, and it will stimulate production of the angiotensin converting enzyme, which will convert the angiotensin 1 to angiotensin 2. I'll not go into details of decapeptide, octapeptide. No, that is not our business here. Just know that angiotensin 1 is a weak vasoconstrictor, and as a result, it will not sufficiently elevate the blood pressure that was detected by the baroreceptors in the kidney. So the angiotensin converting enzyme produced by cells within the lungs. You guys don't do histology, but histology tells us that there are two types of cells in the lungs: type 1 alveolar cells and type 2 alveolar cells. One type of cells produces surfactant factor that maintains the integrity of the alveolus and allows the diffusion of gases. The other one performs these other responsibilities. One of them is through bradykinin secretion, angiotensin converting enzyme will exert its effect. So the angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. So there are two major things that angiotensin 2 is going to do for us, so as to increase the blood pressure. The best way to appreciate these, ladies and gentlemen, is understanding why I stated the formula of blood pressure first. If blood pressure is equal to cardiac output times peripheral vascular resistance, the first thing that angiotensin 2 does is to bind to 82 receptors on the blood vessel wall. When it binds on the 82 receptors on the blood vessel wall, it causes vasoconstriction. The biochemistry involved, we are not going to go into its details. So it causes vasoconstriction. If you cause vasoconstriction and go back to our formula, you are increasing peripheral vascular resistance. If you remove the equals sign on the formula, it means BP is directly proportional to cardiac output. BP is directly proportional to peripheral vascular resistance, meaning that each time you increase one arm, the second arm automatically will increase. In this case, the subject of matter is peripheral vascular resistance increasing because you have produced angiotensin 2. Automatically, blood pressure will increase. The second matter I want to draw to your attention is angiotensin 2 does not have receptors only on the blood vessel wall. Angiotensin 2 also has receptors on the adrenal cortex, where it stimulates the adrenal cortex to produce aldosterone, which exerts its effects on the collecting ducts or collecting tubules to cause sodium and water reabsorption. If you go back to our formula, if you increase sodium and water reabsorption, you are increasing the circulating volume, therefore the cardiac output will increase and the blood pressure will increase. Is there any question before I proceed?
I'm just appreciating the angiotensin converting to enzyme inhibitors here.
Excellent. So those we shall talk about at the end, and we shall not spend a lot of time there because this is introduction to non-communicable diseases. We are not covering details, but I'm going through the normal, so that's very easy for us to understand where we are heading to next and why we shall intervene the way we are going to intervene. The other important aspect for us to appreciate is that the kidney and the autonomic nervous system are not the only things that control or regulate blood pressure. For example, studies have showed that the atrial walls, especially the right atrium, the cells of the atrial wall have the ability to produce a hormone called the arterial natriuretic peptide hormone, or what people abbreviate as ANP, arterial natriuretic peptide hormone. The natriur there refers to sodium, because when we are talking about diuretics, we usually want to commit ourselves to diuretics per se. Diuretics increase on the elimination of water, but we also have what we call natriuretics that are specific for elimination of sodium. But let's all agree from our basic physiology, transmembrane transport, there's something called the co-transport that is under secondary active transport. It is either co-transport or counter-transport. Co-transport means there is a movement of an ion in the same direction with the movement of another ion. The commonest example is like sodium with chloride, sodium with water, sodium with iodide, like in the thyroid gland, etc. The counter transport, you know it, the commonest is sodium, potassium. But we also have sodium with magnesium, etc. So for us, we are interested here in the co-transport, that each time you eliminate sodium, natriuresis, you eliminate water, diuresis. So as a result, the guys who cover the pharmacology mainly talk about diuretics because the sum total of effect seen is each time sodium goes, water goes. I hope that makes sense. So if you are asked about mechanisms that regulate arterial blood pressure, you can talk about your autonomic nervous system, where you talk about sympathetic and parasympathetic and the baroreceptor reflex. You can talk about the arterial natriuretic peptide hormone produced by the atrial walls. you can talk about the renin-angiotensin aldosterone mechanism. It is important for you guys to appreciate this as we proceed. So after understanding what the normal blood pressure is and how it is regulated, it's important for us to talk about the risk factors for hypertension. Now remember, I told you when you are asked a question in the exam, please make sure you classify your risk factors into those that are modifiable and those that are non-modifiable. Right now, because we are running short of time, I'm not going to go into that classification. I am giving you the responsibility of getting these risk factors, and you classify them into modifiable and non-modifiable. So things like age, smoking, metabolic syndrome, where we have things like obesity and dyslipidemia, things like diabetes mellitus, things like smoking, alcohol consumption, sedentary lifestyle. All these are known, documented, and well-studied risk factors for hypertension. Let's classify hypertension. Hypertension is mainly classified into two. Hypertension can be essential or it can be secondary. The other name for essential hypertension is primary hypertension. I'm obviously keeping in mind that we all understand that to make a decision on changes from normal to abnormal, you need to appreciate that systolic blood pressure is the numerator and diastolic blood pressure, diastolic reading is the denominator. The systolic reading is picked when the heart is in systolic phase, meaning during that time the heart is contracting and ejecting blood. The diastolic reading is picked when the heart is resting, but not resting per se. It's the resting here is because it's not contracting, but in actual sense, during the diastolic phase, the heart is filling with blood. From this contraction and resting, there are two words that are picked. I want every one of you to go and read about them. Preload, afterload. Preload, afterload. I am also assuming that you remember that what we are using to measure blood pressure to make this decision is an instrument called a sphygmomanometer. And sphygmomanometers can be manual, like the aneroid one and the mercury one, or they can be digital. Most preferred, ladies and gentlemen, is manual, unless you are regularly calibrating your digital one and servicing it. It's also important to remember how we take blood pressure. These are the simple, to the public health practitioner, these are the things you need. Because if you go out there and make errors while screening a population, the results you're going to get are going to be wrong results. So we are saying the patient should be in a quiet environment, patient should be at rest, he should not have smoked or consumed a hot drink, he should not be anxious, and then we take the blood pressure. The cuff should at least admit 1 to 2 finger breadth. It should be at least 2 finger breadth above the cubital fossa. And the tubing should be in line with the brachial artery. And then we inflate at a rate of 10 millimeters of mercury per inflation. As you inflate, you should feel for at least the radial pulse. And when the radial pulse disappears, you inflate 10 millimeters of mercury above that. Then you place your diaphragm over the cubital fossa and start deflating. I am not going to teach you. I'm not going to teach you the protocol of sounds, the ones we hear. That is the internal medicine. It is not public health. But at least we are saying at the end of the day, deflate at a rate of 10 millimeters of mercury per deflation. Because like you all know, when we all got our first opportunity to take blood pressure, what would happen? You'd inflate up to 130, and when you're deflating, you'd quickly move from 130 to 40 millimeters of mercury. And then you have to quickly deflate back up, and then what happens? At the end of the day, you get a wrong reading. So, It is important for us to appreciate that from this systolic and diastolic reading, a patient can have only one blood pressure value elevated. Commonly, it is the systolic that can be elevated in isolation of a normal diastolic reading. Such a diagnosis is referred to as isolated or lone systolic hypertension. Isolated or lone systolic hypertension. Those are the patients who come in with a BP of 180 over 70 millimeters of mercury, 150 over 80 millimeters of mercury. The systolic is elevated, the diastolic is normal. But the common cases we get are those where both systolic and diastolic readings are elevated. And that brings us to the classification. If you are essential or primary hypertension, and you'll agree with me that this essential primary hypertension are the commonest cases we are going to find in the community. They're the commonest cases that come to our outpatient departments, etc. They're the patients on the ward. So systolic, essential or primary hypertension accounts for 90 to 95% of all the high blood pressure or hypertension we see in our day-to-day practice in the community or at the health facility. The unique thing about essential primary hypertension is the cause is not known. However, many studies have attributed the elevation to blood pressure to some form of heredity or familial or genetic predisposition. Now, someone will ask, the genetic or family, the gene here is in relation to what? So the gene here is usually in relation to either lipid metabolism. The abnormal gene is related to salt natriuresis. The abnormal gene is, that kind of stuff. Those are the risk factors that we have looked at earlier on. That as much as I'm taking salt and patient X is taking salt, patient X has a genetic predisposition to poor salt metabolic mechanisms. And as a result, they will tend to retain a lot of salt as compared to me. And if you retain a lot of salt, co-transport, the salt, which is sodium, will retain water and you will expand plasma. If you increase plasma, you're going to increase on the cardiac output. If you increase on the cardiac output over time, the patient will develop high blood pressure. Am I making sense, class?
Yes, sir.
Class, are we together? I hope I'm not talking to myself.
Yes, sir. We are together.
Yes.
So if someone asked you, you're conducting a health education talk, and he asks you, in hypertension, what does this genetic predisposition exactly mean? The abnormal genes we are talking about, ladies and gentlemen, are in handling or in conducting normal physiological mechanisms. So the abnormal genes are, for example, in salt metabolism, the abnormal genes are in lipid metabolism, and so on. Now, remember we said that genetics is a non-modifiable risk factor. However, if we are saying that the gene is in abnormal salt metabolism, we can leave the gene alone and say, reduce on the amount of salt you take in that, or stop taking salt. If the abnormal gene is in lipid metabolism, we can say, no, cut down on the unsaturated fat or saturated fat, or completely restrict fat in your diet, reduce on the fast foods you consume, etc. We are not doing anything to the gene because there's nothing we can do in the first place. But what the gene influences to cause disease in the patient is what we are manipulating. So I shared with Derek content on the dietary approach to stopping hypertension, also commonly abbreviated as the DASH protocol. You'll notice that in there, what they are doing, they are manipulating those things that the gene can have an influence on. For example, salt, diet, especially lipid metabolism, but we have nothing we can do to the gene. How do we make a diagnosis, ladies and gentlemen, of essential primary hypertension? There will always be a positive family history of this disease. So they will tell you on the maternal, paternal side, there's someone who has hypertension. You will know this is the direction we are taking. The other type of hypertension is the secondary hypertension. This accounts for 5 to 10% of all the cases of hypertension that we interface with or that you have interfaced with. Now, secondary, logically, would mean it is due to a known cause. So there are very many causes, very many secondary causes of hypertension. So we can look at things like drugs, where we have sympathometics like epinephrine, ephedrine, where we have non-steroidal anti-inflammatory drugs because of their sodium retaining ability and their ability to constrict the afferent arterial and retain water and salt in the body. Corticosteroids, combined oral contraceptives, etc. Kidney disease, for example, renal artery stenosis, whereby now the afferent arterial will not receive any blood. And remember, if the afferent arterial doesn't receive blood, ladies and gentlemen, there is no way we are going to filter the blood. So we are preserving sodium and water in the body. This is going to expand the plasma, the blood pressure will get elevated. But also, key to note, if the blood reaching the afferent arterial is less, there is nothing reaching the glomerulus, automatically the kidney will assume that the saturating volume is low, so the RAS will be activated, further worsening the condition and then turning the patient hypertensive. Endocrine disorders like Cushing's disease, there's a tumor of the adrenal medulla. We usually refer to it as a pheochromocytoma. That can also cause the patient hypertension. Pregnancy induced hypertension, where we have preeclampsia and eclampsia. Neurological disorders, etc. All these can account for the secondary hypertension. Now, it's important for us to remember that you will need to make a diagnosis. So how do we make a diagnosis of hypertension? One, the commonest way to make a diagnosis of hypertension is to measure the blood pressure. Now remember, the patient will come in with symptoms suggestive of hypertension. But we can all agree that the commonest presentation of hypertension is actually the one that is accidentally captured during routine screening. The patient ideally looks normal. So when you're reading about hypertension, you will see something like hypertension is a silent killer. It's a silent killer because there is progress of disease when a patient is asymptomatic. So that is why most of the interventions now, like the public health interventions, are recommending screening of populations, both at risk and those not at risk. So if you have an at-risk population, screen it for hypertension. What do we mean? If a patient conducts a sedentary lifestyle, if a patient is of a given age, if a patient has a certain history, if a patient has a pre-existing indication, compelling indication, screen. It's like what we shall see under the cancers, that if at a given age, 60 years and above, the risk of developing cancer of the prostate increases. Don't wait for people to get to 60. Create screening programs that start screening the at-risk population at 40 or 45 years. Let us have a program where we say every 45-year-old male should report to the health facility and get their prostate examined and get their PSA values analyzed and then get a feedback from the attending physician. Prevention. And that is why we are in this particular session. Early features of hypertension. include things like you have come across some of these patients: blurring in vision, occipital headache, loss of concentration, poor sleeping patterns, fatigue, etc. Some are constitutional or non-specific, others are specific. Other presentations can be based on what the cause of the hypertension is. And the other presentations can be based on which organ is being affected by the hypertension. So how do we make a diagnosis of hypertension? One, the patient's presentation, but we are saying most patients are asymptomatic. The other thing is, and the commonest is, screen, measure the blood pressure, and decide which category your patient or your client is in. The other way is to look for the causes and then also look for the complications. So at times the blood pressure may appear normal, but when you screen for something else, you can find what is likely to cause the high blood pressure. Or the high blood pressure may be present in the patient, but then as you screen for these other things, you're likely to make a decision or make a diagnosis of what is actually causing the high blood pressure. So apart from measuring blood pressure, you can carry out investigations like blood analysis. And here on blood, you can look at a fasting lipid profile. You can look at an oral glucose tolerance test. Fasting lipid profile, you want to rule out the hyperlipidemias or hypertriglyceridemia. You want to rule out the hypercholesterolemias, etc. Then we are saying you can look at the fasting blood sugar or oral glucose tolerance test to rule out the diabetes mellitus, since diabetes can complicate into hypertension. You'd want to look at the renal function test to rule out renal disease as a cause of hypertension or even as a complication. You'd want to look at the ECG and the echo. Rule out complications. You'd want to look at a chest X-ray. You'd want to look at an abdominal ultrasound scan. On blood, you can still do a thyroid function test because, like you have seen, hyperthyroidism, in particular, Graves' thyroiditis or thyrotoxicosis, can increase the patient's blood pressure. It's important for us, as we are investigating the patient, to remember that we have said some can be causes and others can be complications that you're looking for. So this would bring us to what is the end organ damage of hypertension? Previously called the TOD, target organ damage. What are those organs that a patient is likely to present with complications in as a result of the long-standing hypertension, especially the poorly controlled, or if a patient has not been initiated on therapy early enough? So here we're talking about the eyes, and the complications of hypertension on the eye are referred to as hypertensive retinopathies from retina. Earlier on, I said hypertension is one of the causes of blindness. 2, complications of hypertension can be experienced or can be seen on the heart. And we usually refer to this as the hypertensive heart disease. We can also have complications of hypertension on the kidney, where hypertension can result into even renal failure. And we usually refer to these as hypertensive nephropathies from nephron. And finally, hypertension causes very commonly, it causes central nervous system manifestations or complications. And we refer to these as hypertensive encephalopathy. Hypertensive encephalopathy. If you have read literature on stroke, you will agree with me that hypertension is the commonest cause of a hemorrhagic stroke. So this is a complication of hypertension on the central nervous system. Class, are we together?
Yes, sir.
Is there any question this far?
What I wanted to inquire is so stroke comes under the CNS or under encephalopathy?
No, the encephalopathy will be the general term.
Categorizing all of them.
Yes, all age, yes. Generalizing all the CNS manifestations of hypertension.
Okay, thank you, sir.
I think it was Rasul or something. Who was that who was asking?
This is Asiki Rasul.
Yes, Rasul, let me give you an example. When we say, yes, when you order for an ECG or echo and the chest X-ray and the radiologist says impression hypertensive heart disease. Hypertensive heart disease is not a single diagnosis. Hypertensive heart disease can be heart failure. It can be ischemic heart disease. It can be dilated cardiomyopathy. More often than not, we see patients in whom the radiologist or on CT scan or chest X-ray says features suggestive of dilated cardiomyopathy, query hypertension. So when you see dilated cardiomyopathy in a patient who has hypertension, we are no longer looking at hypertension per se. We are looking at hypertension with complications on the heart. That category or cluster of conditions is referred to as hypertensive heart diseases.
Okay,
yes,
thank you.
You're welcome. Yes, Immaculate.
Thank you, Mr. Sam. I want to take you back to how you diagnose hypertension, the abdominal ultrasound scan. What do you look for in the abdomen? Are you looking for the adrenomedular tumors on the kidney?
You are correct. You are very correct. First of all, you are looking at the kidney itself, and then you're looking at the adrenomedulla. You're looking at the kidney itself, but then you're also looking at the adrenomedulla. Let me give you an interesting finding. One of the commonest causes of a small kidney on abdominal ultrasound scan is diabetes mellitus. At that moment, in those patients, the same category of patients have hypertension. How did the hypertension come about? The hypertension came through a long chain that the patient had a DM. The DM was poorly managed, commonly with type 2 DM. The DM was poorly managed. The DM complicated into a diabetic nephropathy, which usually presents with glomerular sclerosis. The glomerular sclerosis in the DM nephropathy complicated into hypertension. So what you are actually looking for, Immaculate, is not hypertension. You are looking for a cause of hypertension. So we said that to make a diagnosis of hypertension honestly, we only need to measure blood pressure. These other investigations that we do are either looking for a cause or looking for a complication. Unlike these other diseases, if we talked, for example, about coronary artery disease, where we have angina pectoris, myocardial infarction, you'd find that for those conditions, you can make a diagnosis on blood, on ECG. But here, measuring blood pressure are the only skill that you need to make a diagnosis of hypertension. These other things will only help you either capture the cause or capture a complication. But if someone asks you, the following is the priority in the diagnosis of hypertension, and they put for you lipid profile, measuring blood pressure, thyroid function test, renal function test, the answer there will be measuring blood pressure. It's the only skill you need to have. The rest, cause, complication. I don't know if I'm making sense, Immaculate.
Yes, sir.
Cotias is asking, what is commonly seen in practice, especially with prevention of secondary hypertension and patient compliance? Cotias, can you unmute and ask so that I can understand exactly what you are asking? Flavia is saying, so that's why many diabetic patients have hypertension. Yes, Flavia, that is true. However, in practice now, we don't want this statement to exist because we know the pathophysiology, like we are going to talk about diabetes and talk about its genesis. And we are going to see that nowadays we don't allow this to happen. What we do in practice is, depending on the category of diabetic patient we are handling, we can measure their blood pressure, assess their renal function, and initiate them on drugs that work on the RAS. Commonly, we are using angiotensin converting enzyme inhibitors. So you'll find a DM patient on glyburide, metformin, or even insulin with captopril or lisinopril or enalapril. What we are doing is we are protecting their kidney from bringing us complications that can easily result into hypertension. The commonest presentation, Flavia, of the commonest, the earliest signal that your diabetic patient is on their way to developing hypertension is when they start passing protein in urine. We usually call it microalbuminuria. In fact, microalbuminuria is the earliest sign of diabetic nephropathy. Now, if you go back to your basic physiology, if you start releasing protein in urine, you're going to activate the RAS. Because once you release protein in urine, you are reducing on oncotic pressure. When you reduce on oncotic pressure, you are reducing on the force that resists hydrostatic from pushing plasma from the blood vessel into the tissue. So if you pass protein in urine, there is the opposing force to hydrostatic is removed, plasma is pushed into the tissue, intravascular volume is depleted, the afferent arterial baroreceptors will detect it, it will activate the RAS. How dangerous is this? The fluid is not out of the body. The fluid is just out of the blood vessel. It is within the body still. So you're having an edematous patient whose blood pressure is elevated. This is trouble. So we no longer want these things to happen. I wish Jolly was on a call. Where is Jolly? Derek. Derek. Derek, where is Jolly?
She has been on.
Yeah.
She has been on. Oh yeah. I haven't seen Jolly since the class started.
I've just come online. Good morning, Mr.
You've just come online. The lecture is ending.
I didn't have network. I'm sorry.
I think we should change this class and we make it physical.
No, I'm sorry.
Yeah. This is the second time I don't know what you guys are going to write in the assessment when you are just dodging up and down. So class, Derek later, George. So Flavia, the statement you're saying is very true, but then we no longer take that direction. That's why I wanted Jolly, who works in an NCD center, to tell you that now we don't need to wait for the DM patient to get hypertension. No, we start the DM patient as long as we see a compelling indication. We start the DM patient on either ARB, angiotensin 2 receptor blockers, where we have losartan, valsartan, and the likes, or commonly, because they are readily available and cheap, the angiotensin converting enzyme inhibitors. So I hope I've addressed your issue, Flavia. Cotias, the floor is yours.
Excuse me, sir, before Kotias comes in.
Yes, who is that?
This is Flavia. Now, you're saying Flavia, that you're saying on your explanation, like the earliest signal on that patient is the presence of protein in urine. Now, I was wondering, these are diabetic patients, yes. What about these other non-diabetic patients? Should we also consider that as like a signal? When they detect any protein in urine and the patient has come to the hospital, should you also have that as a signal?
Yes, you can. Let me give you an example. I don't know what background you are, Flavia, but if we called on I don't know if it was Sharon, if we called on the midwife, they will tell you that when you screen when the midwife screens a mother who has come continental and they have a certain threshold, members, quote me right, physiological, like in pregnancy, it is allowed to have protein in urine because of hemodilution. Filtration pressure increases, some amount of protein will leak in urine. Not all protein that leaks in urine is a diagnosis of hypertension, pregnancy-induced hypertension. I want you to quote me clearly here. However, the midwives in the class will tell you that if you screen a mother and the mother has a certain threshold of protein, you will suspect hypertension. But then let's even leave that. The ones, if we have any pediatric nurses here who have done training in pediatric nursing, they will tell you that if you have a 12-year-old with a history of pharyngitis or skin sepsis due to anything, and they present with blood and protein in urine, the next thing you need to look out for, their blood pressure will change. It is highly unlikely to filter protein in urine and the BP remains normal. Flavia, have I answered your question?
Yes, sir. Thank you.
You're welcome. Cotias, then we wrap up.
Yeah, thank you, sir. My question comes from, I'm not in the clinical setting, and
Yes.
when with you through this, I realized that the secondary hypertension is becoming like a global burden. And here we are as public health specialists, and I would like to hear from the practice, because after screening, and maybe there is someone is in the pre or mild stage, and there is a package that they are supposed to be given for prevention. And also, before even screening, we want to reduce this burden. How can we, what has been like the compliance in practice, like when those people are met, like you're screening people or you're meeting a different group of people and you're teaching them about prevention of hypertension, how has been the compliance about that specific package for prevention?
Thank you very much. I want to correct you a bit. If we are to look at statistics, Cotias, with the honest truth, I am using around 9 to 10 years of practice. And clinics, medical centers, government facilities, and hospitals. I have not yet seen a day when secondary hypertension will overtake primary hypertension. I haven't yet seen it. Maybe if there are any other people who are practicing and have seen that, they will tell us. The reason as to why Cotias secondary hypertension cannot overtake primary hypertension or essential hypertension is because the cause is known. And as a result, the prevention is easy. Let us think about it. How often is it to find someone taking corticosteroids long enough to develop hypertension? How common is it to find patients with grave thyroiditis? How common is it to find a pheochromocytoma? In my 10 years of practice, I've seen one pheochromocytoma, which even some medical officers and I believe some physicians have never seen. I was lucky that I had traveled and seen the case. I haven't seen, I have not, maybe I will read. I promise you that I'll read about the incidence of pheochromocytoma in Uganda. I am very certain about many medical practitioners who still have the theory they have never seen a patient being managed. So what we are trying to say is that the secondary hypertension is easy to manage, Cotias. Why? The cause is known. If a mother came in and you are screening and you found their BP is elevated and you ask and they don't have a positive family history and you ask if they are taking drugs and they told you they are taking COCs, remove the COCs, stop the COCs, insert an IUD. The BP will go back to normal. So what our main target, like you're going to see in the next chapter, which I'm going to discuss as we wrap up, how do you manage a patient? You're going to see that the main management of hypertension is targeting the primary hypertension because the cause is not known. Even what is explained as a cause, we cannot modify. So we just keep on playing with things in the periphery that this alluded to cause can be able to manipulate and cause disease. This is what I'm trying to say. Does every patient who has a genetic predisposition of hypertension develop hypertension? Does every patient without a genetic predisposition of hypertension not develop hypertension? The answers in either cases is no. You can have your positive family history of hypertension and you die of aortic accident, or you die of old age without ever developing hypertension. But how possible can this, or how can we achieve this? By manipulating those things that the genetic predisposition can influence so as to cause disease. I don't know if I'm answering Cotias or confusing her. Cotias, come back on the call.
Yeah, thank you very much. Because my first question was going to be, is primary hypertension more seen than secondary? That now that you've answered it, so how do we come in then, since secondary can easily be prevented or controlled, then how do we come in then for the primary when we are designing like prevention interventions?
Okay, thank you. So one, I'll remind the class that I mentioned this. I said when I was classifying for you, I said 90 to 95% of all the cases we shall see in the community, outpatient, inpatient, they don't have a cause. You look for all the known causes, nothing. But when you ask them about the family history of hypertension, excuse me, they'll be having it. So that one immediately you put in primary. The other thing I want to remind you is that the genesis of combined therapy in management of hypertension was initiated because of essential hypertension. Ideally, we would be managing patients with monotherapy. But because we don't know the cause, we have to manipulate different pathways of the physiology that we talked about earlier on. So it is very rare, unless it is in a pre-hypertensive phase with a compelling justification. It's very rare to find a patient being initiated on antihypertensive treatment and they are giving them amlodipine alone. You'll find a patient is taking Losartan H, for example. That's the trade or proprietary. That's losartan potassium with hydrochlorothiazide. Hydrochlorothiazide is a thiazide-like diuretic. Losartan is an angiotensin II receptor block. You'll find a patient taking atenolol with Lasix, taking nifedipine with the taking nifedipine with the captopril, taking atenolol with the hydrochlorothiazide. So the other important thing you need to remember about essential hypertension, the one whose cause is not known, but genetics is implicated. We don't know where exactly to touch to manage a patient adequately. So you find a patient on more than one drug that is interrupting the physiology we talked about earlier on to keep the patient protected. Now, that would also take us to the next level, that if it is primary or essential hypertension, chances of the patient getting cured are low. Chances of giving the patient a drug-free holiday are next to impossible. You can only titrate drugs to the lower end. Why? The patient's well-being, ladies and gentlemen, is entirely dependent on interruption of normal physiology. So if you remove the diuretic, the patient will start coughing, the legs will start swelling. If you remove the calcium channel blocker, the patient will start getting a headache, nose bleeding episodes will increase, they will not sleep well at night. Before you know it, the patient will come with numbness on one side of the body. The BP has gotten elevated again. This information you need, ladies and gentlemen. Each time we talk about public health intervention, I want you to understand public health in the 4 levels of prevention: primordial, primary, secondary, and tertiary. In primordial, an individual doesn't have the risk. You put in place interventions to ensure that he never develops the risks at all. That is mainly at an early tender age. What we are doing for our children, you ensure that the child is eating food with more veggies than meat, than the carbohydrate. It is at an early age. For me and you, at our age, primordial will not help. We are now running with the primary, because in primary, the risk factors already exist, but you are stopping the risk factors from continuing and causing disease in this individual. So here is where we talk about personal protection, health education, health promotion, etc. So this stage in primary prevention, if we are to look at, for example, hypertension, we shall talk about the exercising, we shall talk about the consumption of diet, paying attention to saturated and unsaturated content of the fat, how much carbohydrate are you consuming, that kind of stuff. Secondary prevention, on the other hand, is early diagnosis and early initiation of treatment. How do we diagnose? We screen. So we shall say, if you have the ability, screen. Because you're just walking into a health facility, putting your arm and they put the cuff and measure. Some of you have elderly relatives. Screen them for hypertension. Then waiting for you hear that the guy collapsed in the bathroom and he died. What happened? His BP shot all of a sudden. Or a guy was in office, he got a headache, rested his head. I have seen when I was supervising clinical students in Rubaga, they brought a lawyer, a prominent city lawyer, who eventually died of a hypertensive crisis. He rested his head during the lunch on the table, unconscious. They brought him, his BPs were very high. To try and stabilize the patient, the guy had gotten a cerebrovascular accident, try and resuscitate, the patient died. You see, Chirumira is hypothesizing here that these days, most of the government officials die of blood clots. Chirumira, we shall charge you with the reckless utterances. We shall ask you to bring postmortem results. But this is a public secret. This is information that is documented. How many patients die of stroke? How many patients die of hypertensive crisis, and the like. So, screening and the early initiation of treatment. Then tertiary prevention is the things we're talking about, ensuring that patients who have hypertension don't develop the complications. So you'll notice that courteous, all these levels must be put into consideration. So if you identify someone who is at risk of developing hypertension, and they're at risk of developing especially essential hypertension because they have a genetic predisposition, then you initiate dietary approach to stopping hypertension. Then you stop them from taking drugs without prescription. I've seen females who take abnormal dosages of non-steroid anti-inflammatory drugs during their menses because they suffer from dysmenorrhea. This can be very hazardous. It can affect the kidney, cause acute kidney injury, but then over the time, it can also increase on your risk of developing hypertension. So National Drug Authority, for example, is planning to turn some of these drugs into prescription-only medicines because of their increasing burden of complications. So that would mean we shall get to a time in the future whereby you cannot walk to a counter and ask for meloxicam or piroxicam or lonoxicam without having a prescription. Why? The burden associated with over-the-counter utilization of these drugs is very high, especially in terms of complications. So let's talk about the treatment. There are drugs that we use, but then we can also use the non-pharmacological mechanisms or measures. From your basic medicine, they should have told you that when we talk about treatment of a patient, we are looking at the supportive and the definitive. Supportive, that is non-pharmacological, can mainly protect a normotensive from becoming hypertensive or a prehypertensive from actually developing frank hypertension. But we have said that in some cases, even in the prehypertensive phase, we must include pharmacological intervention. However, since our approach is not that of a physician, but the approach of a public health practitioner, we are going to spend more time appreciating the non-pharmacological intervention. And in this case, I wanted to read the document that I sent Derek today, that is Dietary Approach to Stopping Hypertension. This has been adopted. It was mainly designed by the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure. I think we are currently using the JNC 8 or 9. But the last time I made reference to the official document was when we were using a JNC 7. So you can look, look out for which JNC we are using in particular. So when you look at the JNC guideline, they have principles for hypertension management. So they say treat treat a patient who has a BPO between 120 to 139 over 80 to 89 millimeters of mercury if they have a compelling indication. That is what I was telling Ruth earlier on from her statement, that as much as her statement is correct, if the patient has diabetes, if the patient has kidney disease, we do not wait for their BP to go above 140 over 90 millimeters of mercury, because by then the effect will be irreversible. So you look at the GNC approach to treating hypertension. I'll share with you the official document, but then I also wanted to look at the dietary approach to stopping hypertension. Why I usually love the dietary approach to stopping hypertension, or the DASH, it will tell you if you target a weight reduction, to what extent does a certain reduction in a number of kilograms reduce your blood pressure. I don't know if that is making sense. For example, if you adopted a dietary approach to stopping hypertension, a reduction in dietary salt intake will reduce your blood pressure by 2 to 8 millimeters of mercury. A regular physical activity, engaging in regular aerobic physical activity, such as brisk walking, jogging, aerobics for at least 30 minutes, 4 to 5 days a week, will reduce your blood pressure by 4 to 9 millimeters of mercury. So you look at the DASH guideline. It gives you the activity, what is recommended, and the extent of reduction, or the percentage of reduction in your blood pressure. So if you look at this, it simply means that even in a patient in whom pharmacological intervention is recommended, the non-pharmacological must still be effected. So our patient who is taking antihypertensive should also jog, should also walk, should also reduce on the salt they take in the diet, should consume a diet rich in fiber, in fruits, should reduce on the saturated and total fat. If they are to take fat, the unsaturated is what, that kind of thing. And these should run alongside the pharmacological intervention. What am I trying to say? If your patient is taking diuretics but taking salt, a lot of salt in the food. If your patient is taking diuretics and smoking, or is taking beta blockers and smoking, if your patient is taking NSAIDs and is taking diuretics, the effect of the drugs is going to be neutralized, meaning that the amount of fluid that would have been eliminated by the Lasix the patient is taking will be retained by the sodium, retaining or sodium-containing drugs like the non-steroidal anti-inflammatory drugs. So the non-pharmacological intervention for us, the public health practitioners, is what we are fronting. What are we saying? Screen. After screening, remember, looks at the normal and extracts the ones that are diseased. After extracting those that are diseased, initiate preventive protocol. And I'll remind you that treatment is part of prevention. Each time we talk about prevention, people want to stagnate at the primary prevention. No, prevention is a, what we call it, a continuum. It runs from primordial down to rehabilitation. So you as a public health practitioner can start a rehabilitative program for patients with hypertension complications. But I don't know if you're looking at what the cost would look like and how hectic such a program would be. So you will find that we have a lot of what we call wellness centers. If you go, where is Jolly? If you go into some of these wellness centers, like Jolly will tell you, they screen the patients. A patient comes, they measure the blood pressure, they do an ECG, they do an echo, and tell them, you know what, your BP today is 135 over 90 millimeters of mercury. Come back tomorrow. If you have been smoking, stop. Reduce on the alcohol you are taking, this and this. They come back after a week and their BP is persistently elevated. They start them on a small dose of antihypertensive therapy. And over the time, they're able to manage the patient. Putting the non-pharmacological intervention aside, the pharmacological intervention mainly looks at, we have said, either monotherapy or combined therapy. And the commonest practice on the market, in practice, is in clinical practice, is we use more than one drug. because we are targeting more than one, we are targeting to interrupt more than one physiological mechanism. So the classes that we use, the antihypertensive classes that we use, include things like drugs that exert their effect on the nervous system, where we shall have things like beta receptor blockers. In the beta receptor blockers, I will not go into the details, but then you remember from your physiology that we have beta 1 up to around beta 4 receptors. The ones we are interested in here are those ones that block the beta receptors in the heart. Now, remember, we don't have beta receptors on the blood vessels. The blood vessels mainly have alpha receptors. So the alpha receptor blockers will come into play there. So the beta 1 receptor antagonists are also referred to as the cardioselective beta blockers. Please take note. I'll repeat. The beta 1 specific, the beta 1 receptor antagonists are also referred to as the cardioselective beta blockers. And here we're going to have drugs like atenolol, we're going to have drugs like carvedilol, we're going to have drugs like bisoprolol, etc. Now, we also have the alpha 1 receptor blockers, where we have drugs like prazosin, terazosin, doxazosin, etc. We have drugs called ganglion blockers, which are now not commonly used in practice. The commonest ganglion block I think I can make reference to here is risapine. But then risapine is not that commonly used in practice. So we shall not spend a lot of time on it. So we can also talk about drugs that exert their effect directly on the heart. And here we shall talk about calcium channel blockers. Under calcium channel blockers, we have those that are specific for the calcium channels in the heart. And then we have those that are specific for calcium channels in the blood vessel. For hypertension in particular, we usually target the calcium channels of the blood vessel. For angina or ischemic heart disease, we usually target the calcium channels in the heart because we want to reduce on the demand by the heart on oxygen, which is what is resulting into the ischemia and giving the patient chest pain. So here we shall talk about drugs like nifedipine, amlodipine, felodipine, and the likes. Then we shall talk about direct-acting vasodilators, blood antihypertensives that exert their effect by dilating the blood vessel and removing the peripheral vascular resistance. So here we shall have drugs like hydralazine, sodium nitroprusside, and the like, minoxidil, etc. Now, we shall also have a class of antihypertensives that are centrally acting. They exert their effect on the higher center that is responsible for integrating information on blood pressure regulation. And here we shall mainly talk about alpha-methyl dopa and clonidine. Alpha-methyl dopa, you must be familiar with aldomate. It is a commonly used antihypertensive in pregnancy because it does not compromise the fetal-maternal placental unit, That placenta doesn't compromise blood flow through the placenta, and as a result, it can't cause complications. Remember, ladies and gentlemen, some antihypertensives are contraindicated in pregnancy. That's why I'm mentioning all of them so that you're able to understand where would this be used. For example, drug antihypertensives that exert their effect on the RAS, where we have angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers. They are contraindicated in pregnancy. If a woman is a non-hypertensive and she becomes pregnant, we usually change therapy until she delivers. If it is pregnancy-induced hypertension, we never consider them. So you'll discover that the two main drugs for managing mild to moderate hypertension in pregnancy, either the patient will be on the centrally acting, methyl dopa in particular, or they'll be taking the nifedipine. When it is severe, you'll find the drugs like magnesium sulfate, hydralazine, and currently labetalol. So let me go back to our classification. We have now talked about centrally acting antihypertensives, where we have clonidine, C-L-O-N-I-D-D-I-N-E, clonidine, and methyl dopa. The commonest trade name I've seen of methyl dopa in practice is Aldomate. I don't know if any of you have interfaced with this drug, but it's a common drug prescribed for hypertension in pregnancy. So the other class of drugs that we can use that is commonly used in the non-pregnant female and in these other sexes is in the other sex is the drugs, the antihypertensives exerting their effect on the RAS. Now on the RAS, we shall have mainly three classes. One, we shall have angiotensin converting enzyme inhibitors, where we have drugs like captopril, lisinopril, enalapril, fasmopril, etc. We shall also talk about the angiotensin 2 receptor blockers, commonly abbreviated as ARBs. The others, the earlier on class is ACEIs. So here we have drugs like losartan and valsartan. Then we shall talk about diuretics. Diuretics work on depleting sodium and water, and as a result, decrease on the blood volume, and they will be able to exert effect on the cardiac output, and as a result, the BP will decrease. So the diuretics that are used in hypertension are mainly three classes. One, the class that is used in a hypertensive crisis to deplete volume, and it can be used in isolation. You can give IV furosemide and keep the patient on oral antihypertensives, because like you have noticed in practice, we want to avoid using direct acting vasodilators parenteral, because they remove the protective effect of the baroreceptors, and the patient can easily move from hypertension to hypotension and they die. So the first class are the loop diuretics, where we have furosemide, ethacrinic acid, bimentamide, and the likes. The second class that we use is the aldosterone antagonists, which other people usually want to refer to as the potassium-sparing diuretics, but like we shall see, the effect is the same. As you spare potassium, you eliminate sodium. As you antagonize aldosterone, you eliminate sodium and bring in potassium. So usually they lump them together. So drugs like spironolactone and amiloride fall in this particular family. And then the third and final one is the thiazide diuretics, where we have drugs like benroflumethiazide. The commonest trade name on the market is Aprinox. National GMS used to supply a lot of these drugs to the health centers. I don't know if they are still there with the Indro. So they were the commonest: nifedipine, propranolol as Indro, and then benroflumethiazide as Aprinox were the commonest antihypertensives at the health facility. So under the diuretics, we're mainly looking at three classes of diuretics which shall use in hypertension. The loop diuretics, very good, especially in crisis, administered IV. The aldosterone antagonists or potassium sparing diuretics, and then the thiazide diuretics. Please take off time and familiarize yourself with these classes of drugs and what they do and what some of the examples are. No one is going to ask you about doses. This is not internal medicine. It is introduction to NCDs. We just want you to appreciate the concept and identify that if you got a patient like this, as a midwife who has a degree in public health, I think Chirumina earlier on saying refer. You need to refer. I always tell students timely referral is one of the forms of management. If you're unable to understand where your effort should stop and where someone else who is more or well-versed with these particular conditions should start from, you're going to kill patients. So you'll go for a community outreach. We have seen these things. You go for a community outreach, and while there you find a patient that is severely ill. You can't say, no, for me, Mugambe equipped us with this information. No, you are practicing in which capacity? So when you are going for that outreach, you went in which capacity? As a public health practitioner or a clinical officer? So even if you went as a clinical officer with background knowledge, or who is a certified public health practitioner, is this particular case within your docket? Is it in your jurisdiction? Can you manage the patient? If not, refer. So that brings us to the end of hypertension as a non-communicable disease. Are there any questions? Have we learned something? Are there some things you need clarity on? Over to you.
Thank you very much, Mr. Sam. My question, it was about why we recommend using the manuscript manometer instead of auto. Yet you realize it depends on the skills of the person using it. And the errors of the human errors are at a bigger percentage compared to the computer or technical machine. So why would you recommend the manual, not auto? Over to you, sir.
Thank you. Is there anyone who wants to give it a go? What does the class think? Why do we usually recommend BP to be measured using a manual than an automated sphygmomanometer?
Hello.
Yes, Flavia? Yeah, okay. Godfrey first, then we got Flavia. Yes, Godfrey. But Godfrey, next time, put your hand up so that we know who wants to participate. Yes, Godfrey.
I apologize for that, sir.
Yeah, please carry on.
Maybe what I want to submit in, the reason why, and the reason why we normally prefer the manual BP other than the automated one. These automated BPs, for example, in a hospital facility, if we are using dry cells for the first time, the first patient may have the correct BP if we have used the first new ones. The second one, we may not be sure. The third one, because of their depreciating in power as time goes on. But for the manual BP, you can really easily detect the diastolic and systolic pressure by your own, not even relying on a machine, what it will tell you. Maybe what I can recommend, if in case you're using a digital BP, you can take the blood pressure of a patient in case it comes out when it is very high, then please affirm it or confirm with the manual BP, not to get an error when you're diagnosing a patient in case you are showing he has hypertension. I submit, sir.
Thank you very much, Godfrey. I entirely agree with you. I'm seeing Chirumira, the lazy Chirumira. Chirumira, you're still very lazy. I hear it is for learning purposes for the student. Which one is this, Chirumira? The automated or the manual? Chirumira, can you unmute?
Yes, sir.
So, yes, Chirumira. So which one is most preferred? If you are the attending cardiologist.
No, for students, I said for students it's manual. You have to first learn how to measure it before you get used to automated. That's what you used to tell us.
Hey, that's what I used to. Chirumira is just very notorious. Chirumira, let's hear from Flavia. Yes, Flavia, then Justin.
Yes, sir. Actually, my submission was similar to Godfrey. From experience, the digital BPs depends actually for you to get the accurate readings, depends on the type of batteries you've used. So, and it depends on how long they have taken. So actually my submission was the same like him. So if they are new, like the first patient you've used the first, that at least gives you an estimated accurate reading. But the second, third, you always get errors. Thank you, sir.
Okay, thank you. Over to Justin before we wrap up.
Okay, thank you, sir. With automated BP, normally for us, the one we have in the clinic, though it is using the battery, we fix it in the socket. And then when it is full and you remove it, when you begin to measure, it gives you wrong readings. And when you compare with the manual, when you go back to manual, it gives you the reading exactly which is there. But when you rely on that automated, you might end up treating the person with knowing that this person is hypertensive. But when you go to manual, it will give you the exact reading. So in that case, me, I prefer manual because manual gives the exact reading, which is not somehow fake with the automated.
Okay, thank you very much. I think we are now agreeing. If you move down to Ruth, she's saying automated BP monitoring with multiple readings taken while the patient is resting is more accurate than a manual BP reading in primary care patients. This one, Nambi, you've gotten from the internet. Automated require calibration to minimize errors. That usually is not the practice, hence wrong reading. So Immaculate, I think all the machines, whether manual or automated, will need calibration. That is what I think. However, Ruth's interpretation is here. White collar hypertension. White collar hypertension is a non-treatment category of hypertension whereby the patient's BP gets elevated because of their presence within a hospital or medical setting. Their BP gets elevated because they're in a hospital or healthcare setting. They usually used to, I think they still refer to it as white collar hypertension. So in this particular case, what Ruth is recommending is a self-measured blood pressure in your normal setting. For example, you're in office or you're at home, is likely to be more accurate than a blood pressure reading taken within the health facility because of the factors we are talking about. The anxiety of being in the healthcare facility, the fear of the interventions that are going to be carried on, it is. However, if we are to look at accuracy in measurement, manual BP measurement gives us a more accurate or is associated with less errors as compared to automated. Because with the manual, you are able to get a reading that is accurate for a given individual. Because you see with the automated reading, automated BP measurement, it carries every individual to be the same. So as a result, there are higher chances of getting or errors in BP measurement using the automated than with manual. So as per how the individual presents, the manual BP reading is likely to capture the patient better than automated. Stewart says, but for manual, since you are reading the BP manually, it's like you are recalibrating the BP machine every time you use, while for unautomated, they're almost never recalibrated. Yes, taking BP using automated and when repeated gives different results, yet on the same, that's the challenge. And this is something that I also wanted to make reference to. I want all of you to try this out with your automated BP machines. When you get a page, even if it is just 2 minutes apart, and you use the automated BP machine, a patient will give you 120 over 80 millimeters of mercury, and 3 minutes later or 5 minutes later will give you, or even a minute later, will give you 110 over 70 millimeters of mercury, which is highly unlikely because remember, reproducibility of results is what makes the test valid and reliable. So if reproducibility of your test instrument or your testing kit is questionable, then the results that you get out of this are likely not to be accurate enough. Is Jolly on call? Jolly?
I'm around.
Jolly, share the experience of your boss and we see. What does Dr. Chigundu prefer using? I don't know if you've worked with the Dr. Lwabi, because I have at least interfaced with Dr. Lwabi. He prefers taking the blood pressure manually. Even when the nurses at the station have taken the blood pressure and sent the results, he will repeat the blood pressure himself. I've seen children are talking about experience, but I think this is a basic skill that all health practitioners should have. Jolie, what is the practice at your center?
Mainly we use automatic. If it's really needed, that is when he uses the manual one.
So when you say when it is really needed, could this be to make a diagnosis?
Yes.
All right. So thank you very much. So this is Derek, I hope you're getting the feel of what we are talking about here. Yes, if it is screening, then this would, yes, if what you're doing is screening and you have large numbers, maybe you wanted to cut on the time and everything, you can use the automated. But if we are going to make a diagnosis, because this is the practice with the physicians I've worked with, and it is also what I have been practicing. If I'm to make a diagnosis of hypertension, I will not make it based on an automated BP reading. I will not. I would have to measure the blood pressure manually. Most clinicians have challenges on how to take BP if the machine is of best quality. Auto is better. But you see, Ruth, you are now behaving like Paul. You are encouraging laziness. No, there is no clinician who should have a challenge with measuring blood pressure. There is no clean. These are basic skills. It should actually be unheard of, because these automated BP machines actually were not meant for the health workers. The idea behind the automated BP machines was meant for the patients. Like how you have glucometers, a patient is at home, they can do their what? Their blood sugar readings as they administer the insulin. The same thing with these BP machines. The automated BP machines were meant for the layman, so that he can put a cuff, press it, inflates and takes, not for the hospital setting. But over the time, they are taking over hospital setting because of that tendency to want to shift. But then you'll notice that if a patient is a non-hypertensive, or you want to make a diagnosis of hypertension, then there'll be need for you to take the BP manually. Challenges with taking BP may be there if you have hearing. Okay, yeah, those are some unique circumstances. Any other question? I think we have by far answered, Derek, to the best satisfaction. Any other concern? Please remember that anytime you're asked about a question to do with prevention, please approach it using the WHO standard of primordial, primary, secondary, and tertiary. Do not forget that, please. I'll share with you a PowerPoint on prevention and control of communicable and non-communicable disease. But then I think you have covered the introduction to communicable disease. They should have taught you the levels of prevention. Do not forget that. I have seen more often than not, a question is asked, people get excited and scatter answers. You come in, look for the classification, marks off. Then you come and mark these answers in isolation, and then someone says, no, Mugambe has a problem with me. I did my question, I knew I'd gotten my 25 marks, the guy gave me 15 or even 10. The way you package the information is ideal how you're going to do it when you qualify, and this is what we are looking for. Any other questions?
Bosco's hand is up, and also
yes.
Moodle enrollment.
Yes, Bosco. Enrollment, I'll do it during this week. I had a very busy week last week. we shall do the enrollment within this week.
Thank you so much, Dr. Sam, for dissecting for us this hypertension. Like, I also wanted to inquire, why is it recommended that we should take blood pressure like from either hand? For example, take on the left and then the right hand. And what causes like the blood pressure variation in such circumstances?
Ideally, what we are looking at is the aspect of symmetry. You will agree with me that I don't know if you're a clinician, but cardiovascular examination is we use the inverted J approach. That means you use a handshake approach. As you shake the patient's hand, you take the pulse. I'm giving you the inverted J. You move from the pulse, you go to the BP. From the BP, you go to the JVP, jugular venous pressure, and you move down to the precordium. So symmetry does not start from blood pressure. Usually symmetry starts from pulse. In fact, the necessity to measure blood pressure on both hands is not determined during measurement of blood pressure. The necessity to measure blood pressure on both hands is usually determined at pulse. The characteristics of pulse are rhythm, rate, because we feel for the rhythm first and then make a decision if we are going to measure for 30 seconds or the whole minute. So rhythm, rate, volume, strength, and symmetry. So the symmetry is you should feel the pulse. There is a delay. Anatomically, they tell us there is a delay. But then on actual palpation of the pulse, this delay is negligible. So that means if I'm take radial pulse at the when the radial artery is passing over the bone, if I'm feel for the radial pulse should be felt or palpated at the same time on both the left and right arm. One of the cause that I've come across that causes variations in the pulse on either arms is a condition called coarctation of the aorta. You have a narrowing that is common at the descending aorta. So that narrowing tends to cause pressure to be high above the narrowing and then low below the narrowing. But then even arteriovenous fistulae can cause alterations in pulse on either sides. Anything that alters pulse, that causes asymmetry of pulse, will cause asymmetry of blood pressure. And the commonest in practice should be coarctation of the aorta. Bosco, is that clear?
It's clear, thanks.
Eston, when do we say someone is in a hypertensive crisis and what is the presentation of the same? Maybe if I give you a read up, but then most of the hypertension, if you have seen a patient in a hypovolemic shock, Eston, if you have seen a patient in hypovolemic shock, then you have seen hypotension. Most of the features of hypotension are hypoperfusion. So the patient will have CNS, mainly CNS symptoms, dizziness, so drowsy, loss of concentration, memory, obviously the BP reading less than 90 over 60 millimeters of mercury, then cold, clammy skin, cold extremities, the glomerular filtration will decrease. So if the patient is catheterized, the patient should be now starting to enter oliguria. All of those can be manifestations of hypertension. When do we say, and then how is the, so I hope I have answered your question. When do we term blood pressure if you have a systolic but unrecordable diastolic? Okay. This is early. I will not go so much into the details, but then the best way to appreciate this, it's very rare to find that a patient has a systolic and they have an unrecordable diastolic per se. I know you're talking about a number of mothers that come to antenatal clinics in plasma expansion, in the arteriovenous fistula, etc. What we usually do early is we go back and study the crotal of sounds of blood pressure, phase 1 to phase 5. So in a patient in whom you have measured using our usual standard approach, and you get to phase 5 and the heart is beating, even the blood vessel is fully dilated, what you do is you repeat the measurement. However, you now use phase 4 as your diastolic reading. Phase 1, the first sound you get is systolic. Phase 2 and 3, there is an increase in the sound. At phase 4, there is a change from increase to a decrease. We call it muffling of the heart sounds. And then phase 5 is disappearance, which we record as our diastolic. Those are referred to as the crotal of sounds of blood pressure measurement. So in a patient in whom you get a 0 diastolic and they have, let's say, 100 systolic, but then you have deflated to phase 5 and the sound is not disappearing, you measure the blood pressure again. However, you record your diastolic at the point of muffling. So when the sounds are turning from high to low, that is what you record as your diastolic reading. The midwives are more familiar with this because it's a very common presentation in pregnancy because of the physiological changes. For example, hemodilution, expand plasma with a reduction in HB. That large volume will cause the heart to continue beating even when the blood vessel is fully dilated. Ali, I don't know if I've answered your question, Ali.
Yes, you have. Thank you.
Yeah, so you can read about. Yes,
there is
please.
A question which was in the chat. It was asked by Apio. It was talking of a woman having multiple sexual partners and then reducing their high blood pressure. I think she can clarify more.
I am not seeing the question. Where is that question? Derek, I'm failing to see the question.
Let me paste it again in the chat. I've copied it.
All right. I'm seeing Immaculate saying the day you'll be told to take blood pressure on the limb, you will see. Yeah, I think Immaculate, you're correct. The people need to have the skill. It's important you have the skill, 100%, and this is an inexcusable issue. I understand the feeling that Ruth was presenting is actually what is there in practice. I entirely agree with you, Ruth. But then I would blame the training. But then also it depends on whom we are talking about. Because if a laboratory technician or a laboratory technologist is, let me use technician because the technologists who are doing BMLS in most of these public universities are sharing classes with what? With the medicine and surgery and pharmacy students. So we expect anyone who is a health worker to know how to measure blood pressure. Honestly, take temperature, take pulse, and record the measure respiration. These are vital observations. I don't know how you can convince me that you are in a crisis, and then say for me I'm let's say what laboratory technology, I cannot measure blood pressure. You look for an answer. It would be an unacceptable incident. I have heard that women that have multiple sexual partners usually get high blood pressure during pregnancy. Is it true? If Immaculate, no, I am not certain. I'm not certain about this. I am still trying to look for the association between, because the pathophysiology, Immaculate, of pregnancy-induced hypertension is known. Honestly, it is known. The role of the placenta in producing diffuse large amounts of vasoconstrictors and inhibition of the endothelial-derived nitric oxide is known. This pathophysiology is well documented. How it is related, however, to multiple sexual partners, yet the woman is already pregnant and the placenta is already established, is what I'm not getting. If I were to derive from my own experience, I don't think this hypothesis is correct. So you can maybe look at stress, but for it to be a cause, no, not really. But we can all go and read. Could yeah, Lubega Richard, yes, this is what I was just telling. This is what I was just mentioning. We could blame it on stress. But as a cause, I highly doubt, because pathophysiology of pregnancy is known. If there are no other questions, thank you very much for attending the session. Please read, please attend, because most of our information and notes, we shall generate them during the session. Please attend. I don't know how Eston is going to attend on your behalf, and then he's going to give you the notes he wrote. You'll be in a lot of trouble. And I'm doing this so that we can attend and attend in full. Do not get tempted to continue missing the session, because you'll miss out. And then at the end of the day, we shall have a bit of challenges here and there. So our next session, we are going to discuss diabetes mellitus. I'm trying to look at the big ones. I'll give you a reading material. You find it on the platform. Reading material on the coronary artery disease. It is another non-communicable cardiovascular disorder that is accounting for a large burden of disease. You have heard of people who drop dead, and when they do a postmortem, they find the guy had a very big coronary embolus, or he had the gross narrowing of his coronary vessels. So the continuum of disease that ranges from angina pectoris or ischemic heart or myocardial ischemia down to sudden cardiac death or myocardial infarction is what we generally refer to as coronary artery disease. And those are the ones that we shall be covering in cardiovascular disorders, hypertension and coronary artery disease. Then we shall look at diabetes and continue looking at the rest as we have planned in the course outline. If there are no questions, have a good Sunday. Derek, I'll share that information I've given you with the class.
I already shared.
So they have it. Yeah, because usually my first test online has hypertension, it has coronary artery disease, it has diabetes, and epilepsy. Then the second test will have gender-based violence, it will have cancers, it will have trauma and injuries, and then risk factors, and then monitoring and evaluating of non-communicable disease programs, and then the NCD policy, which I will share with you guys. So when we get to a certain time, you will know that now we're about to do the test, so you prepare. But then the earlier you do, the better. Have a good day.
Okay, likewise, sir. Thank you.
Have a good day too.
Likewise.
Thank you.